This is a classical measurement of a pressure volume curve in the pulmonary function test lab using transpulmonary pressure and going from the residual volume up to total lung capacity. And this is something we know for years and years. And you see that when you reach total lung capacity, your pressure, your transpulmonary pressure here, is around something like 30 centimeters of water, which means when total lung capacity is a voluntary maneuver, but when you reach your maximum distension of alveoli, you're close to 30 centimeters of water. Why I'm saying that? I'm saying that because this is a very simple basic mechanics notion which has changed the face of ARDS. This is a study which just did in 2002, so 2 years after the publication of the ARDS net trial, which limited the plateau pressure to 30 centimeters of water. And before the ARDS trial, to make it a bit schematic, the studies had very high pressure. Unfortunately, we found very few studies which measure the plateau pressure. So each dot is one study where you have the plateau pressure measured and the incidence of barotrauma. And before this area, the incidence of barotrauma in ARDS was 50%, 60%. And then we say, well, it doesn't make sense to push the alveoli above their total lung capacity, above 30 centimeters of water. And now barotrauma has disappeared. It's, the incidence is between 5 and 10% in most of the study, since we apply this basic notion of respiratory mechanics. So this is one of the reasons why we need to measure respiratory mechanics. And the principle is based on the notion that we are ventilating a baby lung, which has been so well described and emphasized by Luciano Gattinoni. The classical CT show one part of the lung which is aerated, one part which is gasless. This part looks relatively small because it's atelectatic, but it's, imagine it should be more than 50% of the lung. It's the complete lower lobes which are completely atelectatic here. So we are really ventilating only 30% of a normal lung. And we now have tools at disposal at the bedside, not very complicated to measure, which tell us important information about what we set on the vent and what's the interaction with the patient. The compliance is directly correlated to the lung volume. The lower the lung volume, the lower is the compliance. The lowest lung compliance you can find are in babies, and that's why we have baby lungs in adults. And I can tell you that baby lungs in babies, it's the smallest possible compliance to find. And this compliance is volume divided by the elastic pressure, which is the driving pressure, plateau minus PIP. So the driving pressure is tidal volume reported to compliance. So it's tidal volume in relationship to lung volume, which is exactly what we want to know the risk of ventilation. And therefore, we are not surprised to see that there is this strong relationship, the strongest of all parameters on the vent, between driving pressure and mortality. You all have seen this curve, where driving pressure above 14, 15 centimeters of water is associated with a significant increase in mortality. And we found also the same data in the real life. So in observational study, this is the lung-safe study, you see a clear separation in the survival curve for patients ventilated with driving pressure above or below 14. So very important, relevant information. So the measurement of respiratory mechanics, which we described recently, benefit from the use of the esophageal pressure, which can tell you what's the real distending pressure of the lung and which can tell you what's the pressure inside the chest. So the these measurements can all be done at the bedside with really minimal equipment. Here is an example of tracings where you have the ventilator tracings, the flow, the airway pressure, then you have the esophageal pressure, which again is really simple to measure at the bedside. To have the two curves on the same monitor maybe an issue, but now ventilators offer to put additional pressure on the screen of the ventilator. And the last curve is the difference between airway pressure and esophageal pressure, which is called the PL, L for lung, which is transpulmonary pressure, so this is the distending pressure of the lung. And in this, just visually, you can understand here that if you look at the airway pressure swing and compare to the esophageal pressure swing, you see that the amplitude of the airway pressure swing is much larger than the amplitude of the esophageal pressure. And this is because the esophageal pressure is only the part which is moving the chest wall. The airway pressure is the total pressure distending the lung plus the chest wall. So if you remove the chest wall part, you have the lung, and this is what is indicated by the transpulmonary pressure. So what I'd like to show you very briefly that it's possible to implement this measurement systematically in an ICU. We reported this very preliminary data about our experience of implementing a bedside assessment of respiratory mechanics, including esophageal pressure, in patients with ARDS. So in our ICU, since 3 years now, every patient with ARDS has an esophageal balloon, and we do these systematic measurements of respiratory mechanics, including the basic resistance, elastance, measurement of transpulmonary pressure, plus a number of very simple tests which help clinicians to better titrate the ventilator, hopefully. So another test we added is what's the benefit of PEEP in these patients, which really is a big question. And we do a very simple bedside measurement of what we call the de-recruitment, which is the capacity of the lung to be recruited or de-recruited. Our reasoning is based on the fact that if the lung is recruitable, well, the patient should potentially benefit from a relatively high PEEP. But if the lung is not recruitable, we should set the PEEP the lower possible to maintain sufficient oxygenation. So what we do is one maneuver at the bedside, which is illustrated here, where you see we first decrease the respiratory rate for a few breaths, so we have time for long expiration, and then we abruptly decrease the PEEP from here a level of 15 to a level of 5. So in one breath, the PEEP is decreased by 10 centimeters of water. And we just look at the next breath expired on the ventilator and record what the expired tidal volume. And of course, before this maneuver, inspired volume, expired volume are the same, but then you have a much bigger expired volume. So if we subtract the inspired volume, we have the volume which was kept by this PEEP level of 15 above the PEEP 5. And then we do a very simple calculation. We say, well, if the patient is not recruitable, the change in lung volume should be perfectly predicted by compliance. For instance, if your compliance is 30 milliliter per centimeters of water, you change the pressure by 10, you expect a change in volume by 300. That would be like a balloon with no recruitment or de-recruitment. If we found that the level of tidal volume, exhaled is 300, we say, or 310 or 350, we say this patient is not recruitable, so we should not use PEEP. If, by contrast, we found that the volume exhaled is 500, 600, we say, well, there was a lot of volume in addition to what was predicted by the compliance at low PEEP, so this patient is highly recruitable. Of course, we don't only look at mechanics, we also look at oxygenation. And we have in mind this data from Johan Golliger, who looked back at the effect of PEEP in the randomized trials when patients were submitted to high PEEP from their baseline. And what he showed retrospectively was that patients who responded in terms of oxygenation, so this is the delta PF in millimeters of mercury when the patients were switched from their initial PEEP to the high PEEP arm of the study. He showed that the better was the response in terms of oxygenation, the lower was the mortality. In other terms, patients submitted to high PEEP with a good response in oxygenation seem to benefit from high PEEP, whereas patients who had no response to high PEEP, or even a decrease in oxygenation, seem to have a higher mortality. So we integrate all these data, the mechanical recruitability, the oxygenation response, the hemodynamic response, and we decide, based on no algorithm, but just an integration of all these data, whether the PEEP level should be adjusted. And this is just to show, we look at our data after having included 1 year, something like 65 patients, and we found that we had 3 categories of patients. Some in whom we decreased the PEEP level after this measurement, some in whom we did not change the clinical PEEP level, and some in whom we increased the PEEP level based on these measurements. What's interesting was that the oxygenation index, which is using both the oxygenation and the mean airway pressure, was significantly improved in all situations where we changed the PEEP, either decreased or increased. And when we look at the global population, and this table may be a bit hard to see, we were very interested to see that on average we were able to significantly improve oxygenation. You could say, okay, that's not a big deal, it's easy to improve oxygenation, but at the expense of lower airway pressure. You see that the driving pressure went down from 18 on average to 15. And the oxygenation index increased, and what we call the oxygenation stretch index, where we replaced the mean airway pressure by the driving pressure, was significantly improved. So that was a very good surprise to say, well, we can offer better oxygenation to our patients with lower airway pressure just because we did the measurement and we assessed systematically the response to PEEP and the recruitability of each individual patient. So I have no data to show that it improves survival, but it really improved all the physiological parameters which are associated with a better survival. And just to finish and continue on the talk by Antonio, we also keep the esophageal pressure when patients are switched to pressure support, because we think that monitoring the transpulmonary pressure swing during spontaneous or assisted ventilation is also very important to continue a lung protective ventilation. Can be done by very, very simply adding the pressure on the vent plus the negative swing in esophageal pressure, and it gives you an idea of what total transpulmonary pressure the patient and the ventilator are developing. And for some patients we say, well, it's higher than total is close to 30 centimeters of water. It's better for the protection of the patient to go back to sedation and even paralysis if needed in some cases. So in summary, I think for individualizing mechanical ventilation, we need monitoring at the bedside. Respiratory mechanics is a very feasible monitoring, which I think should be much more frequently implemented in our ICU. Thank you very much.